Okay, good afternoon, everyone, or good evening. So
Good evening.
yeah, we will continue our class on gout and hyperuricemia. Yeah. Okay, so our case, this Mr. Elton John, EJ, yeah, 52-year-old male, school bus driver, reports to the emergency department with the primary complaint of extreme pain in his right elbow. Yeah, so right elbow. He admits to playing several games of basketball yesterday, followed by a few beers with friends. He awoke in the early hours of the morning with a sore and stiff elbow, which he self-medicated with acetaminophen, paracetamol, before trying to get back to sleep. He sought medical attention when his pain escalated to the point where he was unable to apply pressure to the area and struggled to move his arm. Pertinent medical history include the recent diagnosis of hypertension and obesity. At visit with his primary care physician 1 month ago, EJ was prescribed hydrochlorothiazide 12.5 milligram once daily, which is his only medication. He was also encouraged to go on a diet and to increase his exercise. So, what will be our from this small short story, short history, yeah. So which one you think is important?
The extreme pain.
Extreme pain. Okay, so from the beginning, age. Do you think important age?
Yeah. Age. Male. He's a male. Male are much more prone for gout.
Yeah, correct. Yeah, and then pain. Yeah, so this is extreme pain. So elbow. So yeah, the location, because gout has locations that are common. Yeah, and how about this beers? Any?
Yeah, beer can increase the uric acid in the body.
Yeah, okay. And then how about
And then the
the
pain.
time? Hmm.
Yeah, early morning pain. Yes, the stiff elbow.
Hmm. Okay. So these are all important, yeah. But because we are geared to the to the gout, let's say if this kind of patient go to the pharmacy, there will be a lot of wide range of things that we have to decide, right? Okay. So when he was able to, how about this part? Is there anything important in this part?
The risk factor.
Uh-huh. Any
Hypertension, obesity.
obesity. So what's the relation between obesity and uric acid?
Obese patients tend to have high uric acid concentration.
Mm-hmm. Because of what? Because of
For clearance, maybe.
yeah, and then maybe they diet, right? They take everything that is
Uh-huh.
yeah, everything non halal. No, I mean that yeah, IV, the Chinese like all this bakute and all this, right? So probably yeah. So all
Yes.
the uh, and then we have got how about the medicine?
Hydrochlorothiazide.
Mm-hmm. Is there any
Potassium.
relation? Is there any relation between thiazide and uric acid?
Thiazides are potassium sparing diuretics.
Is it potassium sparing thiazide? Is it a potassium sparing or a thiazide diuretic? Thiazide.
Thiazide diuretic.
Yeah, potassium sparing is
Spironolactone.
spironolactone. Okay. So there is relation, right? Because thiazide can decrease the excretion, yeah, of uric acid. Okay, so he states that he has no drug or food allergy and is tolerating the antihypertensive well. On physical examination, the right elbow is exquisitely tender. Tender here, tender means painful, yeah. Tender does not mean it is soft, no, yeah. But in clinical language, tender means painful. And erythematous means redness, yeah. There is redness. And his vital signs are all within normal limits. The elbow is warm, okay, one thing, warm to touch and has moderate swelling, okay. So, can you tell me before we go to the lab, right? So this can be what are the things that we can think of beside gout? It's open to interpretation, right? Because I think when you have pain, just pain, so can be different things, yeah. Maybe can what are the most common uh, causes of pain? So we have to see whether this is joint pain or muscle pain, right? Or for diabetes, what kind of pain that they have? Neuropathic pain, yeah, neuropathic pain. So, how do we differentiate? For example, like rheumatoid arthritis
The location of the pain?
location, yeah. So when we say, actually between the rheumatoid arthritis and gout, yeah, can be almost similar the location. But the rheumatoid arthritis normally has multi joint, not only one joint, because rheumatoid arthritis is a systemic disease, yeah. So it tends to attack more than one joint. So maybe if you have knee, maybe two knees will be attacked, yeah, maybe one knee and another joint. So there will be different joints. Whereas gout, because gout is deposition of crystal, yeah, so it can also be multi joint, yeah, but normally it starts with one joint first. And so maybe we also can inquire about, maybe because he plays games, right? Maybe any accident, any bump into something, yeah, any. And also we see whether got any, what they call this, um, injury, yeah, to the hands, to the elbow. Okay, so but then laboratory test to confirm, right? So you have the serum uric acid, yeah, serum uric acid. When I send you, I have not converted this one, so now I have converted already. So from milligram to millimole, so these are all in millimole, yeah. So we see that actually the uric acid is a bit high, right? 0.61, yeah. So 0.61, a little bit high, not too high, yeah. But the urea is still okay. Serum creatinine is okay. And WBC, what do you think of the WBC? It's quite high, yeah. In the high side,
Yeah.
yeah, but it's not too high, but it's quite high. So we can say maybe there's an inflammation going on there, right? So we can also order other things like what are the markers for inflammation? Uh, CRP, yeah. Another one is what? ESR, yeah.
ESR.
Yeah, ESR and CRP. And for rheumatoid arthritis, we will order for rheumatic factor, right? RF, rheumatic factor, just to confirm, yeah. But we can also ask him whether he has got this kind of pain before, yeah. And also whether the family members have um, any gout before or not, yeah, the family members. okay, because it tends to run in family. A radiograph of his elbow shows soft tissue swelling with no evidence of tophi. Yeah, so we know what is tophi, right? So the disposition of the uric acid and becomes very, you can see it. Yeah, there's a tophi. Yeah, like a small hills. Yeah. All right. So if tophi is there, so it's easier for us to diagnose. So the definitions, gout is an inflammatory condition of arthritis type. Yeah, that so arthritis simply means that this is inflammation of the joints. Yeah, results from deposition of uric acid crystals in joint spaces, yeah, and surrounding tissues. Unfortunately, we can't see the crystal, right? Except if we do the synovial fluid examination, yeah, leading to an inflammatory reaction that causes intense pain, erythema, and joint swelling. Okay, it is associated with hyperuricemia, defined as serum uric acid more than 0.36. Yeah, for this patient is 0.6 just now, kan? And there are the different value, yeah, the normal value between women and men, a little bit different lah. Yeah. About 10% of people with hyperuricemia develop gout. Yeah. So not all people with hyperuricemia develop gout. Yeah, only 10%. But 80 to 90% of patients with gout, they are hyperuricemic. Yeah, maybe I can say that people with hyperuricemia for a long time, yeah, maybe for long term and very high, yeah, they can develop gout. Yeah, and gout normally is occurs because of the hyperuricemia. Okay, common illness occurs in men 5 times more than in women. So you correct already, yeah. Normally in older adults, seldom in children or in adolescents. And family predisposition exists. Okay, pathogenesis. The hyperuricemia is caused by, I better correct the typo first before I forget later. So the hyperuricemia is caused by so there are two causes, very simple, that is overproduction of the uric acid and decreased excretion, 90%. So we tend to think that people with gout, yeah, maybe they are not careful with the diet. Yeah, they eat a lot of beans, a lot of proteins, yeah, meat, but in fact these are only contributory 10%. Yeah, but the excretion that is 90%. Hyperuricemia causes deposition of urate crystals in the synovial fluid, which cause inflammation, vasodilation, increased permeability of blood vessels, activation of complements, and leukocytes. Yeah, that's why the leukocytes increase. Phagocytosis by leukocytes causes cell lysis and release of proteolytic enzymes. Yeah, so these enzymes will cause damage to the joint. Yeah, and the inflammatory process causes joint pain, yeah, erythema, warmness, and swelling. Deposition of urate crystals called tophi, yeah, can occur at late phase. So like this patient is still early, so he doesn't have tophi. The location can be in the fingers, toes, yeah, olecranon bursae. So that is in the in joint, yes, in all the joint you have the olecranon bursae. Ulnar part of the hand, so it means that our hands here, yeah, and then Achilles tendons on the legs, yeah, and then knees, wrists, and also hands, ankles as well, ankle also, yeah. Okay, so if we see the pictures, So these are typical of gout. When you see the here you can see toffee. Yeah, toffee. The tophus is for one, but if they have more than one, then we call toffee. Yeah. Now, uric acid itself, yeah, is produced by from breakdown of purines, and purine come from three sources: from food, yeah, meat, internal organs, seafood, beer. Yeah, that's why I mentioned internal organs, because I think bakute have a lot of internal organs. Yeah, conversion from nucleic acids of the cells. So meaning that when our cells burst, yeah, lysis, so there are a lot of nucleic acids that can come out from the cells. And also the novo synthesis from purine bases. Yeah, so it means, sorry. So the new synthesis, yeah. So all these three. So meaning that we get it from the food, or it can be synthesized by our body. Yeah. So this is biochemistry lah. Yeah. And 600 to 800 milligram uric acid is produced daily. Then one third is excreted in the feces and two-thirds in the urine. Yeah, because it's tend to be more water soluble. Yeah, and 90% uric acid is filtered in the kidneys and then reabsorbed. Yeah, so just like our sodium, yeah, sodium more than 90% are reabsorbed. So our body recycles a lot of things. Yeah, our body. Okay, drugs that can decrease uric acid excretion, like thiazide. Just now we mentioned thiazide. Yeah, ethanol, um, TB medicine, yeah, like ethambutol, and then pyrazinamide, yeah, levodopa, hydrosalicylate, cyclosporine. Yeah, here again I need to correct the ethambutol, pyrazinamide. Okay. All right. So this diagram here. So we consume purine in diet, and then produce also by the cellular metabolism just now. Yeah. So and then you have the intestine eliminate one third, two third in the urine. Yeah. And then you have got here. If you see this purine metabolites breakdown, yeah, by xanthine oxidase, we make the uric acid. And uric acid, now here, uric acid is changed to allantoin in the mammals, but not found in humans. Yeah, so we are lacking of this enzyme, uricase. Yeah, we don't have uricase enzyme. Yeah, so that's why we have the accumulation of uric acid. So we have to get rid of the uric acid that we produce. Yeah. But so here are where the drugs, yeah, so like allopurinol, febuxostat, this one they inhibit the xanthine oxidase. Yeah, so they can so we prevent, yeah, from the high uric acid. Or there's a new drug called pegloticase. Yeah, pegloticase. So this is a inhibit. No, this is actually a uricase. Yeah, a uricase enzyme that can change uric acid to allantoin. Yeah, so this is very. I think this gout, yeah, is the easiest topic lah for all the. So it's very easy. Okay, overproduction of uric acid. Overproduction is caused by abnormalities in the enzymes that play roles in the synthesis. Yeah, so increase the activity of this PRPP synthetase. Yeah, again, let me synthetase. Okay, synthet synthetize synthet yeah, synthetase. I think like that. Um, Increased concentration of PRPP, so it will increase the synthesis of purine and deficiency of this enzyme, hypoxanthine guanine phosphoribosyl transferase, yeah, HGPRT. So hypoxanthine cannot be converted to guanine. More uric acid is produced. PRPP is needed in this reaction, so this PRPP, yeah, so the overproduction of PRPP will also cause overproduction of uric acid. Now, excessive breakdown of nucleic acid, for example, in high cell death, yeah, like what we learned last semester, like chemotherapy. Yeah, so we have chemotherapy, then you have cell death, yeah, can cause breakdown into the of the nucleic acid. Or high cell turnover, for example, like a type of leukemia, myeloproliferative disease. Yeah, so means that there are a lot of blood cells, yeah, certain blood cells, yeah, in the myeloid, yeah, the myeloid, yeah, like lymphoma, myeloid. So it's kind of, for example, what we call this, lymphocytes and all this, yeah, being produced. So there's a high cell turnover, yeah, so it will cause increase in nucleic acid as well. So these are the diagram, yeah, how the PRPP just now, right, plus glutamine, yeah, will produce all these things. All these things. So PRPP itself, yeah. So by this enzyme and the PRPP, it makes the guanine to guanilic acid, then to the nucleic acid. Yeah, CR. So these are the PRPP. Yeah. So the uric acid is here. Okay, so if you have the PRPP, then later on you assemble, become the uric acid. If lacking of PRPP, no PRPP, so we also have less uric acid. Now, the second cause, yeah, decrease in uric acid excretion. Normally, uric acid is not accumulated if the production is balanced with its excretion. Yeah, 90% of gout is caused by this impairment of excretion. The exact etiology is unknown, probably because of genetic disposition. Uric acid nephrolithiasis occurs in 10 to 20% patients with gout. Yeah, so it means that there are small amounts of patients with gout, they can have the kidney stone, yeah, uric acid kidney stone. The etiology, excessive excretion of uric acid, yeah, and because of acidic urine, because uric acid is acid, so you need an alkaline, yeah, so that they can be soluble. So in acidic urine, it becomes crystallized, yeah. So then it will become the kidney stone, and concentrated urine as well. Yeah, because you have more concentrated urine, it means that less soluble. Now, so now key checkpoint in gout pathogenesis. Yeah, overproduction, under excretion. Yeah, hyperuric acid, formation of the crystal, and if supersaturation can cause this, yeah, crystal. Okay. Or maybe there's a pH, temperature, yeah, joint trauma, and protein as well. Can cause acute gout, yeah, and then resolution. And then after that, it will, because after it, when the inflammation has subsided, yeah, then you have resolution there, okay? But there is still macrophage, etc. Yeah, and it can come back as well, yeah. And if in the long term, yeah, because it's no more inflamed, but the uric acid is still there, yeah, so you have the formation of tophus, yeah, tophi, yeah, tophi, yeah, not tofu, yeah, tophi. Okay, so the etiology here, Yeah, so diminish excretion, etc. Then drugs, you see, thiazide and loop diuretic, yeah, cyclosporine as well. And you have the increased production like myoproliferative, we mentioned already, yeah, and all the and inherited disorders. Okay, now clinical presentation we have got. Oh, why I have the bahasa one? Never mind. Later I translate. Yeah, I forgot to translate this one. Okay, acute and sharp pain normally occurring at night. Nah, so you are correct already, yeah. Occurring at night and awaken in the morning with pain. The attack is in a single joint, monoarthritic, yeah, as compared with rheumatoid arthritis, which is often polyarthritic. Joints affected, metatarsophalangeal, yeah, so joints of the toes, ankles, Achilles joints, knees, wrists, and elbows. Redness, swelling, warmness, sometimes accompanied with fever and raised WBC. So we see it in this patient. Duration of symptoms 3 to 14 days, yeah, from 3 to 14 days, like 2 weeks, yeah, if untreated. And what are the things that can triggers? Yeah, so these are the triggering factors like stress, trauma, alcohol, infection, surgery, yeah, and too fast, yeah, too fast in lowering down the uric acid, okay, and also to drugs that can increase uric acid, just like thiazide, yeah. So later on I will translate it. So the joints, yeah, distal phalanges, yeah, middle, okay, proximal, metatarsal, tarsal, calcaneus, talus, yeah, distal. So distal interphalangeal joints, okay, proximal and metatarsophalangeal joints. So these are the three joints, yeah, very prominent for this. Okay, lab test. So you have uric acid. Okay, I have not converted this one later. Maybe I convert it to the millimole. So for Malaysian, it's easier. During the attack, it may not be very high, but it gradually increases in a few days or weeks. Creatinine and urea to check the kidney function. So we also can aspirate the synovial fluid and look at it in microscope. Then we can see the urate crystals. Yeah, quite pretty actually. Yeah, pretty. Yeah, so like this blue color, yeah, yellow color. Okay, like needles, long. Normally, the synovial fluid looks cloudy because of leukocytosis. Okay. Now, our goals of treatment to stop the acute attack, yeah, or in other words, to relieve the symptoms, to prevent future attacks, yeah, and to prevent complications like urate nephrolithiasis, and that is the kidney stone formation, and deposition of the crystals in other tissues. Now, as all the treatment, we have got non-pharmacologic and pharmacologic, yeah, and pharmacologic we have got the acute treatment, yeah, and also the prevention. Now, the non-pharmacology treatment, cold therapy with ice, may help, yeah, but you can't be, like using ice for all the time, right? So just to alleviate the pain. Diet, yeah, low purine diet, supplements, yeah, but there's a note here. Herbs such as celery's root and flaxseed are not encouraged. So for acute gouty arthritis, we have got three, yeah, that is NSAIDs, colchicine, and corticosteroid. Now, NSAIDs, yeah, effective and minimum side effects for short-term treatment, like indomethacin, naproxen, sulindac, yeah, start within 24 hours of attack, 24 hours of attack. And during the duration of 5 to 8 days, lower the dosage afterwards, day after. Yeah. Side effects, as we know, gastritis, hemorrhage, and perforation, renal function decline, raised BP, sodium and water retention. And COX-2 selective medicines like celecoxib can be used, but we must be aware of cardiovascular side effects. Now, secondly, corticosteroid. Yeah, it can be given oral or intra-articular. Yeah, it is as effective as NSAIDs. Prednisone or prednisolone, 0.5 milligram per kg per day for 5 to 10 days. Yeah, so let's say if the patient has 60 kg, so you give 60 or 30. Yeah, 30 means, yeah, depends on the tablet. Yeah, quite high actually. 30 to 40 normally you give for asthma attack, right? Acute asthma attack. 5 to 10 days. It can be stopped immediately. Yeah, no need to, gradually lower down, or you can also lower it down the dose at the day 7 to 10, because you need only 5 to 10. Yeah, you take 5 days, so the day 7 to day 10 you can lower down the dose already. Okay, triamcinolone 20 to 40 milligram as intra-articular injection if only one or two joints involved. Because if you have many joints involved, what dose you can give? Because you every time you give 20. So if more than that, then it will be like overdose already. Yeah. Patients will still need oral NSAIDs, colchicine or corticosteroid. Yeah, or corticosteroid, not atau or corticosteroid. Okay, and then side effects, hyperglycemia, hypertension, hallucination, peptic ulcer, osteoporosis, cataract, muscle atrophy on long-term use. Now, third, colchicine. Yeah, colchicine very effective to alleviate the pain if given within 24 hours. The effectiveness declines after 36 hours. First dose 1.2 milligram, and after 1 hour we give 0.6, followed by 0.6 milligram BID. Yeah, so how we give? So the first dose 1.2 milligram. Yeah, then after that wait for 1 hour, then give 0.6. Then after that, we just wait for the next one. Yeah, wait. For example, if I given in the morning, so we wait in the afternoon or evening to take the another 0.6, and thereafter we do the BID. Yeah, side effects: nausea, vomiting, or else diarrhea, neutropenia, neuromyopathy, yeah, and which risk increase with statin. Drug interaction with P-glycoprotein and CYP3A4 inhibitors, yeah, such as clarithromycin. P-glycoprotein. Erythromycin also, right? So caution with patients with kidney and liver impairments. Okay, mechanism of action. Yeah. So this also I will translate later. Yeah. So it is. So this is colchicine. Yeah, colchicine. It will bind to the tubulin. Yeah, and will disturb the mobility of granulocytes. Yeah. So the granulocyte. So phagocytotic of uric and acid crystal by neutrophil. Okay. So release of leukotriene and other mediator of inflammation. So it also inhibits the synthesis and the release of leukotriene before and interleukin 8. So it decreases the production of TNF alpha, yeah, by the macrophages. Now, so our acute gout management, yeah, so mild to moderate to severe. So we see initiate monotherapy, yeah, either it is NSAID, colchicine, or systemic corticosteroid. Okay, so if severe, then we can combine colchicine plus NSAID or colchicine plus oral corticosteroid, yeah, NSAID plus intra-articular corticosteroid, or even colchicine plus intra-articular corticosteroid, yeah, or it can be the oral corticosteroid plus intra-articular, yeah. And if adequate response, then we just switch to the alternative monotherapy. If adequate, yeah, treatment outcome successful. Okay, so we do the education, yeah, dietary plan for the patient to prevent a future attack, initiate urate lowering therapy. So after the acute phase, then we prepare the patient for the prevention. So if inadequate response, so we try interleukin 1 inhibitor therapy. Now, second type of drug that is prevention of acute, yeah. So first, the non-pharmacology, we have got patient education, weight management, regular exercise, limit on alcohol, diet, limit the intake of corn syrup rich in fructose, and food rich in purine. Eat more vegetables and dairy products. Review medicines that can increase concentration of uric acid, such as thiazide just now, yeah, cyclosporine. All right, the pharmacotherapy drug therapy is recommended for patients who have more than 2 attacks per year, although their uric acid concentration is normal or slightly raised. Yeah, so this is for prevention sake, or if the patients have TOFI, yeah, TOFI, chronic kidney disease or history of kidney stones. So when we start the medicine to lower down the uric acid, we have to give the NSAIDs together. Because why? Because when we lower down the uric acid, there can be a chance, yeah, a risk that the acute attack will occur, yeah, trigger the acute attack, because it actually create an imbalance, yeah. So now after after balance, then the uric acid become toffee already. So now if you lower down the uric acid, so those uric acid become toffee, then they have to break down again because of the balance, yeah. When they break down, there's a process that is painful, yeah. So the target uric acid less than 6 milligram per liter. First line xanthine, of course, first line allopurinol, yeah, xanthine oxidase inhibitor. Second line is probenecid, which is uricosuric acid, drug, yeah. If patients cannot tolerate both, then we can use the new drug pegloticase. Now, prevention of recurrent attack. So either we inhibit the uric acid synthesis, allopurinol, or we increase the excretion, yeah, by the uricosuric acid like probenecid and sulfenpirazone. Now, xanthine oxidase inhibitor mechanism of action, yeah, to inhibit xanthine oxidase, to inhibit the xanthine oxidase. Which converts hypoxanthine to xanthine and xanthine to uric acid. Example, allopurinol dan febuxostat. Okay, so when you see this hypoxanthine become xanthine, yeah, that is the OH here, right? The OH, and then become uric acid, yeah, from xanthine to uric acid. So we want to block this, yeah, block this. So allopurinol dosage starts at 100 milligram per day, then increase every 2 to 5 weeks to reach the uric acid target, maximum 800 milligram per day. For patient with impaired renal function, we start with a half dose. Yeah, the side effects: skin rash, leukopenia, GI problems, dizziness, skin allergies like urticaria, toxic epidermal necrosis, and toxic epidermal necrosis and erythema multiforme can occur. Yeah, so I have seen patient on this, yeah, toxic epidermal necrosis from the from because of allopurinol. Yeah, because I thought allopurinol is very common drug lah. Yeah, but in fact it can cause this. Yeah, which can be fatal. Now, the new drug, febuxostat, yeah, 40 milligram OD increased to 80 milligram OD after 2 weeks if the target is not achieved. Side effects: nausea, joint pain, and increase in LT and AST. Now, another type of drug, uricosuric medicine, yeah, like probenecid. Probenecid inhibits the absorption of uric acid. Yeah, so it increases the excretion. Contraindication for patient with history of kidney stone and severe kidney disease. Starts at low dose, give enough drinks plus potassium and sodium citrate to alkalinize the urine. Yeah, so we know that, so that it will be soluble, water soluble, yeah, to prevent kidney stone. Initial dose 250 milligram BD, yeah, for 1 to 2 weeks. Then after to 500 milligram for 2 weeks. Now, side effect: GI irritation, skin rashes, kidney stone formation. Yeah, so uric acid secretion reabsorption. So it basically will inhibit the reabsorption of the uric acid. So then the uric acid will be excreted. Now the last medicine, pegloticase. Yeah, just now we already learned it is a uricase enzyme that exists in other mammals and made by DNA recombinant technology. It converts uric acid to allantoin, which is water soluble. We can give it by IV injection. Yeah, uric acid concentration will decrease in 24 to 72 hours. But the side effects like allergic reaction, yeah, give together with antihistamine and corticosteroids for prevention. Yeah. So our algorithm will be the last slide. Yeah. So whether does the patient have an indication for urate lowering therapy? Yeah. So if yes, then we can use the anti-inflammatory gout prophylaxis, yeah, like low dose colchicine, yeah, low dose NSAID, second line low dose prednisone and prednisolone. Okay, or ULT initiation like xanthine oxidase inhibitor, allopurinol and febuxostat, and probenecid, yeah, alternative. Non-pharmacology, of course, we know already just now. Then if achieve urate target, no, then titrate to maximum dose. Achieve target, yes, then continue all measure. Okay. If no, then if using XOI, xanthine, yeah, is an allopurinol, yeah. Add auricouric. So we can actually add two drugs, yeah, allopurinol plus probenecid, for example, yeah, or plus losartan. So achieve target, yes, then okay, then no, then they switch to pegloticase. Okay, so here, yes, then evidence of gut activity while taking ULL, ULT, while taking this drug, yeah. Yes, continue prophylactic therapy. If no, then whether got tophus or not, yeah. If yes, tophus, discontinue the prophylactic therapy after 6 months following achievement of urate target. So if no, no tophus, continue prophylactic reaction therapy during the greater than 6 months. Discontinue, yeah. At the greater of 6 months or 3 months following achievement of urate target. Okay, so this is the algorithm for management of hyperuricemia in gout. Okay, any question from here? It's quite easy, I think, yeah, quite easy to understand. I will,
No,
I
sir.
will, I will translate that one boxes now, and I'll give to you. Yeah, I will upload this. Okay, if no question, then my plan is to have another class on Tuesday evening.